we were amazed by what we can see in Australia. So today we focus the whole afternoon on antimicrobial stewardship. I will not introduce Karin again because we know very well her long CV and her expertise. I would like to start immediately because, as I said, we have several hospitals connected and several initiatives we want to discuss. So we try to start immediately. We will start with the lecture of Karin on the organization of antimicrobial stewardship in Australia. We will then introduce the stewardship and the SAVE project in Verona. Then we have Walter Zing from University of Geneva introducing the REVERSE project. Just for you, probably you have already some information, Karin, about REVERSE. REVERSE is the project where we have 24 hospitals introducing as a stepwise design just microbiology stewardship, then infection control stewardship, and then antimicrobial stewardship to reduce IMR. We will have also nice talk about tailored prophylaxis in immunocompromised patients and personalized prophylaxis in abdominal surgery. And then we would like to give time to each team just to report their experience or just to ask a specific question. For people connected, we will check your question. Is anybody else connected? Okay, thanks a lot, Maela. So Maela will be checking if you have question or if you want just to introduce your hospital, just write in the chat and we will give you the floor just after the Karin Thursky lecture. Karin, the floor is yours. Thanks so much.
Thanks, Evelina. Thank you, everyone who's joined online today, and thanks everyone in the room. I am having a wonderful. I've been here 2 weeks now.
Yeah, sorry, I didn't share the screen. Your slide. Blah, blah, blah. Yeah, I know that you would like to do the Italian one. I'm sorry. You just need to accept. We didn't open R1. Okay, we do it again. 1 second. No, ma sto aprendo da qua. Dove l'abbiamo messo? What is written? No, non c'è. Ce l'abbiamo solo di sì, è qualcosa.
Okay, so as I was saying, it's been very nice for me to be here in the last 2 weeks because I've had an opportunity to understand some of the challenges that you face in stewardship, but also some of the opportunities. And I can tell you from my 2 weeks that all the things that you face with surgeons and cardiac surgeons and hematologists are exactly the things that we face in Australia. I thought it's important to, before I start talking about stewardship in Australia, to understand the Australian healthcare system, because I think understanding. Just speak up a bit. Is that better? Is that better? How's that? Yeah. Is it? It's important before we talk about stewardship to understand how the healthcare system is structured. We have a very high quality healthcare system, and there's been a very large focus for the past 10 years or so in quality and healthcare quality. But as you can see from where the population is around the edges, we do face huge problems, and I talked about it last time about the geographical disparities and delivering healthcare across the whole continent. So we do have issues with equity and access. And also the other thing which is a bit unique, which I've noticed very much since I've been here, is that we have quite an advanced practice workforce in pharmacists. And so they have been playing a major role in stewardship in Australia for probably 20 years now. And there are actually training pathways for pharmacists that support them in this role. But one thing we have found is that we have been late adopters of electronic medical records, and so some of the issues around digitalisation and data, just like you, are still an issue. So our healthcare system is divided into which is funded or managed through the state, so Victoria, Queensland, New South Wales, etc. The states are responsible for delivery of care to the hospitals. Funding goes to the states for the hospitals, and therefore it's the states who set the priority as to what they will fund. That includes setting up statewide antimicrobial stewardship programs, comes down to the state. Unfortunately, it's actually the Commonwealth at a national level that funds community and aged care. This is, of course, where most antimicrobials are funded and where we are very immature in terms of what is done in primary care regarding antimicrobial stewardship. One of the biggest drivers for adoption of antimicrobial stewardship programs, I think the biggest driver, in fact, was the introduction of very detailed hospital accreditation framework. And the Australian accreditation framework has been relatively sophisticated for a good 20 years, but it was taken under a new authority in 2011, where they developed the first set of standards which cut across various areas, including governance and infection prevention, for example. And really was very focused on protecting or improving patient outcomes and harm, rather than being a tick box exercise to be licensed, which I've seen in some countries, accreditation is really more of a licensing exercise, whereas in Australia, it become very much a focus around quality. The way the accreditation frameworks now is it used to be every 3 to 4 years. Antimicrobial stewardship is a mandatory accreditation criteria, and every 2 years you would be accredited, and AMS was always included. If you failed the AMS standard, the whole hospital would fail. So it was a very high stakes criterion, and that meant that our CEOs and our managers were very anxious that we were meeting AMS, and that's actually how many hospitals actually got funding, how they got their sort of pharmacists funded, often not very much, but at least that was what drove it. In July 2023, they changed because they realised that many hospitals were spending months preparing these reports, and the accreditors would come and they'd have a big pile of these reports, and it actually took them away from looking after patients. And so they moved to what's called a short notice assessment. You get 24 hours notice and the accreditors come straight in. That means you don't have any opportunity, and what it really means is that you need to have your policies and your guidelines ready. And can everyone online, if you're not, can you put yourself on mute, please? Thank you. So that's really amazing, and that happened to us this year or last year when they arrived, and that worked well. Thanks.
Non vedo più il mouse. Eccolo.
Oh, okay. Now, I was involved, this is a true story. I had a cup of coffee with the then head of the Australian Commission, Chris Bagley. He was a vet, he was the CEO, and he rang me up and said, Kaz, I want to come and see what you're doing in stewardship. So this was about 2005 or something like that. He said, I want to come and have a look what you're doing. I said, okay. So I said, come over. He was in South Australia. We had lunch. I took him through some of the digital stewardship programs that I was developing. He said, this is amazing. I said, yes, I know. We need to have stewardship as a thing in Australia. He goes, oh, what should we do? And I said, why don't you form a working party? And he goes, oh, we love working parties. As long as what you do doesn't cost anything, I'm happy to have a working party. Who should we have on the committee? And I went, great. I could pick all my friends. No, that's not true. I picked people that I thought that were going to be really strong contributors, and we had a fantastic committee. And we spent the next couple of years pulling together the evidence base around the globe to create this first book, which is available. You can see that there, to create the evidence base for antimicrobial stewardship. And at that time, it was just for the hospitals. It has now been continually updated. It is a live document. And if you look on there, you will see stewardship in Indigenous care, dental health, day surgery, aged care, general practice, and even vets now. And it has been something which we've maintained over time, and paediatrics, of course. In that book was the first time we stipulated the amount of EFT or full-time equivalents that a hospital might need. And you will recall that there was a position paper that I was involved in with a few of the European experts recommending that or challenging what we actually need in FTE. But of course, it's very different compared to in different environments. And also if you don't have the sort of pharmacy and nursing backgrounds that we have in Australia. But anyway, that was very good because we could tell our executives, see, this book says, so what were the accreditation framework? These are the very first set of accreditation frameworks. So our committee helped to define what we thought would be reasonable. And with the introduction of each accreditation framework, there's usually a 2-year period where it's called a criterion in development, where you don't have to immediately meet it, you have 2 years. So when this came in 2014, hospitals had a couple of years to demonstrate that they were looking at the antimicrobial stewardship, that they had a program, that they were prescribing antimicrobials according to guidelines, that they're looking at usage and resistance, and that they were demonstrating continuous improvement. So this is a fundamental principle of all quality systems, that it's never a set and forget. You must always be looking at continuous improvement. And typically when I run my stewardship programs, we don't try and do everything all the time. We pick, 3 or 4 things each year as an activity and try and finish them and deliver, rather than sort of trying to do everything all the time. So this now has become the current framework, and you can see there's a very important, many of these criteria impact stewardship. So things like clinical governance, partnering with consumers. Every committee in our hospital has a consumer, and it's no different to our stewardship committee. We have obviously infection prevention standard where AMS sits, medication safety. In some countries like Canada, antimicrobial stewardship sits under medication safety. My personal opinion is that antimicrobial stewardship probably fits better under medication safety because of the people who do the work. Communicating for safety and recognising acute deterioration where sepsis sits, although for a long time the word sepsis hasn't been anywhere in the standard. Now we do have a clinical care standard for sepsis, and hospitals need to apply. So what does it look like now? So this is you can see here that the standard has become very detailed, and really it's not a kind of in development phase anymore. You need to have a policy, you have access to therapeutic guidelines. We have a very strong restrictions and approval history in Australia, which has been demonstrated to be effective. We do have our clinical care standards I'll talk about in a minute, but also what we look at and we talk about, how do you review your prescribing? We talk about appropriateness explicitly. It's not implied. It's not guideline compliance. It is appropriateness, and we use our NAPS program. Where the areas we're identifying the improvement and how we report that, including appropriateness of prescribing. So this is, I think you can see here that for a hospital, and even a bush hospital with 6 beds, has to think about how they're going to meet the accreditation framework. But this is very important because this has been the biggest driver. And we know that hospitals have seen the accreditation framework as a major driver. And The other thing is Australia has had national, well, I wouldn't say consensus because it's not developed like a traditional guideline, but we certainly have had national guidelines for a very long time. And we can see that some of the NAPs and accreditation framework are key things that tend to drive these programs. Along with the accreditation framework, there's been a lot of work in developing implementation toolkits, and I would encourage you, if you're interested, to go in and have a look because they're very, very detailed and they've been developed to apply to certain settings. And typically in Australia, we have we have principal referral hospitals that have ICUs and bone marrow transplants and 24-hour EDs, all the way down to small bush hospitals up in the Kimberley or in remote Queensland, where they don't have any physicians on site. There might just be nurses, fly-in and fly-out surgeons, and they are not exempt. So we have been developing guidelines to help all those environments. Now, the therapeutic guidelines was really, I guess, a very early attempt at driving the judicious use of antimicrobials, and it was developed by a couple of microbiologists actually at the Royal Melbourne Hospital where I am. And the intent, which was 32 pages, was to develop some simple guidelines to help drive particular drug choices and dosing. And it has now continued. It was sold for $1 and incorporated as a not-for-profit organisation. It's not a consensus base as you would imagine with some of your consensus guidelines. They have voluntary writing groups and they're given topics. Where possible, of course, where possible, they try and pull together the evidence, but they take a very strong stewardship lens as to primary and secondary recommendations and dosing. And it is freely available to hospitals. And for our GPs, they still have to pay a small cost. Even that tiny cost of, I think it's $35, is still considered to be a barrier for some GPs. They say, well, why can't we get it for free if the hospital's getting it for free? It's also not hooked into their EMR, and you'll see in a minute the impact that has on when you're trying to improve decision-making at the point of care. For GPs, they don't have time to be navigating around to all different websites. So this is the clinical care standard. Again, this is something that was developed by a multidisciplinary committee, including patients. It has been developed for both all prescribers. So this crosses all sectors now. This includes aged care, primary care, and hospitals. And they're the core principles of what good antimicrobial prescribing looks like. But the important thing about this particular clinical standard is that they've developed a corresponding set of recommendations for patients and families. So for every guideline, every standard, there is one around what that means for the patient. And the accreditors now try and sort of say, well, how are you meeting the clinical care standards? Now, if you look at this one about patient information shared decision-making, a very simple way that we do it is our pharmacists a couple of times a year on their own wards will walk around to patients and say, do you know that you're on an antibiotic? Many will say, no, I didn't, as you can imagine. Do you know why you're on the antibiotic? Do you know anything about the infection? And it's a very simple survey. I can share the questions for you. And it's very interesting to feed that back to the clinical teams when they realise that half their patients actually don't even know that they have an infection and they're on an antibiotic and that it will potentially have adverse events. So can everybody online please put themselves on mute? Thanks, Mel. Now, this is the Aura program. It's terrible colours, but I hate these colours every time I look at them. But anyway, this is the Aura program. This is the Australian Antimicrobial Resistance and antimicrobial usage surveillance program. It's presented as a pie chart as though we have all this information all together. We don't. So I don't want to burst your bubble, but there are various programs contributing data to the surveillance program. Here you can see our consumption data. We have very high level limited data coming from the community. You can see my program here, the NAPS, the hospital, surgical and aged care. The medicine insight has now been defunded. So the only targeted information is coming from the MCAS team. And then we have some more AMR type surveillance, the AGAR program, which is again, every single one of these programs have voluntary participation. The entire program is voluntary. And then passive surveillance, very slow. You can imagine trying to get data out of various hospital pathology systems, microbiology systems. We do not have an agreed data model in Australia, so we don't have an aligned methodology for monitoring resistance. So some use UCAS, some use NCLS, some use CDS. And so there's this ongoing argument about, what we're using. So again, limited. Now, just briefly in primary care, there is no mandatory accreditation in primary care, but you can see what they do measure against if they choose to be accredited are those clinical care standards, which I showed you that also had the patient information. And this is a very interesting study where we undertook the NAPS, the NAPS program that we do in hospitals about appropriateness and compliance. We undertook a manual NAPS in 11 general practices, and we looked to see how compliant they were with therapeutic guidelines. And you can see here that there's very low compliance with those therapeutic guidelines, which have been out for a very long time, and quite high non-compliance. And the reason is because they are going to the product information database that sits with the electronic medical record, which is not a guideline. So you know how you see ceftriaxone and all so they're just picking because it's connected to their prescribing workflow. And so they were fully compliant with the MIMS. So this is that kind of interesting point to make. When you looked at their appropriateness, you can see compared to hospitals in Australia, which sit between 75 and 85, we've got a bit of work to do. And a lot of that is unnecessary prescribing for respiratory tract infections. To try and improve the prescribing in primary care, there were some policy changes. And one of the things that was happening is in the GP's prescribing software, they automatically had a repeat box ticked. So typically you're seeing a patient for their antihypertensive or their cholesterol medication, you would have the repeat box ticked so that the patient would have at least 1 or 2 or 3 repeats, so they didn't have to keep coming back for the prescriptions. Many GPs had no idea that they had a repeat ticked even for their prescriptions. And so the government now required that you cannot have repeats for certain common antimicrobials, amoxicillin, cefalexin, doxycycline. I mean, Recithro isn't even in any guidelines and you still see it being prescribed. And they also included a comment instead of, I think the old comment was take until the course, till the box finished, or take until the course finished, to this new comment on the script, which is take according to the number of days advised. We still have problems, as probably you do, with pack sizes, which is still a problem, but at least this was a new step. And you can see the impact of the repeat change, although don't forget that was also COVID. So this was our first year of our funded program. That's me 20 years ago. You can see that I haven't changed at all.
Even better now.
Oh, thanks. But, yes, anyway, so Kaz Chen was a very, very first funded AMS pharmacist, and she just started her PhD this year. But we got that funding because we were able to demonstrate that we had saved the hospital around $250,000 in bed stay shortening. And we know that for every patient that we see on stewardship, in 2/3 of cases, we're able to shorten, stop their antimicrobials, and we converted that to bed days, and that was how we're funded. CEOs are much smarter now. They say, oh, we don't care that you shorten length of stay because more people come in. But anyway, back then, that was a good argument. So just a little bit about the NAPS. You've heard me talk about it a lot. This was something, again, this is translation. This has come out of a research program into clinical practice and now funded by government. It was the initial inspiration, I suppose, was Herman Goosen's ESAC program. We did a small pilot. It was not acceptable to our pharmacists and ID physicians because we had already had relatively sophisticated programs, and we wanted to look at something that was much more detailed. And so it has grown into this large program where we look at, we work across various areas. The antifungal NAPS is the newest one, which was launched the year before last by one of my PhD fellows, Anna Kanina. But we do focus on appropriateness, and you can see here that we said a continuous gap in appropriateness and guideline compliance for obvious reasons, because often patients are having directed therapy or complex and a single guideline doesn't suit them. And this is just in the Hospital National Prescribing Survey, but we have another 300 or 400 hospitals doing the surgical prescribing, and over 1,000 aged care homes participating in the aged care NAPS, because there isn't anything else for them to use. And so the NAPS is an online program. As soon as you do your survey and finalise it and assess the appropriateness, you will instantly get your results. And you can see here, just here alone, that difference between compliance with national or local guidelines versus appropriateness. And it's for this reason that our clinical staff really find it much easier to talk about appropriateness. You can use it to be a patient level or drug level. It's very flexible. It's available 24/7. It is set up with local survey managers, so hospitals have it as their own tool. But it's very important to recognise how the data is used, either at a local organisation, at statewide or national. And this is showing you how, and this is when accreditation started in 2015, you can start to see how, you can start to monitor and see how sites are going with their appropriateness.
Just one thing, probably I missed and probably somebody else missed. The definition of appropriateness, which definition do you use?
We created a matrix. It's very obvious what it is. Evelyn has asked, what is a definition of appropriateness? It is a matrix. And so we look at multiple factors, including whether the drug choice, dose, microbiology mismatch, allergy mismatch. For some time, we even included, which we're stopping now, we had, if it was prescribed by an expert in infectious diseases, it was considered appropriate. But you and I in the room all know that actually ID physicians can be really bad prescribers. So that's actually that is being removed. So even our ID physicians. But I can share it around. It's too small to show very well, but I'll share the matrix with you. And I think I'm going to try and organise a demo with the team as well. But it's very obvious. It's not surprising. With the NAPS rebuild, we have gone ahead because it was developed literally over 10 years. We've had our 10 years now. We've gone back to develop gold standard cases and to do the formal face validity of appropriateness with gold standard and interoperability and as part of the redesign. And one of the things, obviously, you need to have a trained workforce. So in order to be able to assess appropriateness, you have to pass the e-learning module, and that steps you through. And what that has meant is that every site, we do have a help desk. So for some remote regional sites that don't have any pharmacists or clinicians available, we help them do their NAPS through the help desk. and we help them assess their appropriateness. We partner with them to learn how to do it. And now we get very few help desk requests for the NAPs because they have learned over time how to assess it.
Are these all hospital annual tests for appropriateness? I mean, all the patients under antibiotic at a certain
At 8 a.m. that morning, including surgical. Yeah, that's right. The surgical prescribing one is can be done retrospectively or prospectively. It's not done as a point prevalence survey, obviously, and we look at all phases. So we look at perioperative prescribing, timing choice, intraoperative prescribing, and postoperative prescribing. The overarching appropriateness in surgery in Australia across all craft groups is 50%. It's terrible. And there are major problems with postoperative prescribing across some of the, well, pretty much all of the groups. So that's a major target for us. This is what our Norse program looks like. It's delivered as a static PDF. There's no ability to do flexible reports, slice or dice. It compares, you know, your hospital and all hospitals. This is in ICU and non-ICU for third generation Kepler-Sporans. We don't particularly feel that it's very fit for purpose anymore. Did you want to?
I was just checking, so you have 30 DDD per 1,000 bed days in non-ICU.
Yes. Is that high or low?
We wish we.
We are well.
Who knows how much is correct?
Exactly, that's my
That's the
point. We've
question.
talked this a lot about how useful is consumption. So what we are doing though is we're currently working with this team because my plan, our desire is to bring the consumption data together with the appropriateness. And what you see when you do that is that the very high use antimicrobials, which are more narrow spectrum, actually you've got large amounts of what we call under the radar use, right? But that if you have a 67% appropriate, that means 1/3 of these high use antimicrobials are still inappropriate. Whereas the low use, which is the carbapenems, actually have very high appropriateness because they're in guidelines. So my opinion is we need to be focusing on under the radar use, which is often missed by stewardship programs, right? It's opposite, right? So what I'm hoping, and we're waiting to see whether it's funded, is we will bring in this data as atomic data and be able to bring it together with the prescribing data. Now, this is getting down to the nuts and bolts of how we typically run stewardship in Australian hospitals. And this, of course, is probably more a larger hospital model. But you can see stewardship committees don't fit very well. So our stewardship committees have to report to drug and therapeutics committees, medication safety, patient safety and quality, infection prevention. We have all the various people in it. And then ultimately you would like it to go up to clinical governance. This is one of the biggest difficulties with stewardship is because it doesn't fit anywhere very well. It ends up being quite a burden in trying to make sure that you're getting the right information to the right executives. And I think that's a long-standing problem. Now, at Royal Melbourne Hospital, which is around about a 500-bed quaternary centre with stem cell transplants, CAR-T, etc. We have 4 physicians doing 0.1 EFT with a full-time dedicated pharmacist shared across 2 pharmacists. Myself and 3 other physicians actually have an embedded role in our hematology, our high-risk hematology, so leukemia. We are the only 4 physicians who do that service because they trust us completely because we understand how to assess patient risk and they will come to us and implement our recommendations without asking. If anyone else junior went in or the general AMS program went in, they would just go, no, what are they doing in my ward? So this concept of handshake stewardship and embedded stewardship in difficult units, I think is a very, very important thing. However, obviously it needs extra resources. And the other thing which we really have found to be incredibly fantastic is we do a twice a week ICU round. Now, when we walk in the room, it's like flies to honey. Oh, they all come and they stand around because they learn all this stuff about antibiotics that they didn't know. It's very friendly. We see every single patient. There are nurses, pharmacists, the microbiologist attends, so real-time checking results. There are many ICU listening to see, oh, can I ask about this? And it's a wonderful round which has been going for a very long time, and they are so good. Every antibiotic, this is a plan, we're stopping at this, you know, it's really fantastic. And in fact, in Royal Melbourne Hospital and Peter Mac, we have mandatory indication. You cannot prescribe an antibiotic without charting the indication, which is very important. Peter Mac is a dedicated cancer hospital. It's around about 150 beds, but very large ambulatory setting, so you can imagine. It's different there. So there we have a AMS roster. So we have the ward roster, a separate AMS roster, and every single physician in our department does 2 weeks of AMS at a time. It's very important for them to, all our physicians, I believe, to understand how AMS works, and also to realise that they get to see patients that are not the typical ID consults. And they're just, and that gives them that exposure and also seeing the under the radar prescribing. What is unique about Peter Mac is that I managed to develop up a curriculum for a nurse practitioner, and this was done through demonstrating that our sepsis pathway saved $8,000 per patient, medical patient, and $32,000 per surgical patient put on the sepsis pathway, as well as our savings with the AMS program. And this was able to fund this new role, which is now APRA accredited. And we also have a digital AMS program, which I'll show in a minute. So what do we do in Australia? Well, typically we have a very robust, there'll be no hospitals that don't have some sort of approval process in place. In some hospitals, like the Austin where Lindsay was, Evelina, they had a mandatory approval. We know that post-prescription reviews are very important, but we know that the models of stewardship are still being developed in less resource sites. And there are many models here where there are statewide support, hub and spoke, telehealth support, visiting AMS physicians, pharmacists-led. So, I mean, I think this is one thing I've taken away from being here, you know, definitely pharmacists are a key facilitator for us. Now I want to talk about guidance, which is something that I developed after a business grant from my MD. I developed a decision support tool in ICU, which showed reduction in AMR. So this guidance was an attempt to create a digital workflow for stewardship. And this was developed before we had an EMR. And so this is understanding how we do traffic light restrictions, how we develop approvals with decision support, how we provide information which is meaningful for pharmacists and nurses looking after the patient at the bedside, how we triage which patients need to be reviewed, and how we use that data for action, how we provide that feedback. And when I mean triage, you know, it's very easy to say, I'm just going to go and see all the meropenams, linezolids and vancomycins or cipros. Actually, it's more sophisticated than that. You know, you need to see patients who are complex sepsis. It may be that they have staph bacteremia or candidemia. It's not so much about the drug. It's not a drug-led stewardship. It's about the patient-led stewardship. And this one was able to demonstrate very significant changes, as well as reduction in resistance in a few pathogens. And at the time that one award was reviewed by Journal Watch, and this really has continued, it's been around for a long time, since 2005. And over the years, it has continued to be, look, it's very terrible. You see, I didn't have a human factors person there. But anyway, I can see how it alerted the team to who needed to be seen. We started to have a post-prescription review process that was more sophisticated. This is Kirsty in ICU and our ICU pharmacist and our AMS pharmacist rounding in ICU and collecting information so that we're able to provide meaningful data back to the clinicians. In 2023, we decided to completely rebuild the program, and that was because we had annual forums with all our users across the country about what they wanted. And unfortunately, because people wanted decision support for all conditions, not just by drug, that tipped us into what's called a medical device or an exempt medical device, which then became quite a huge undertaking. And a comment here is that we know that having it hooked into your EMR is very, very important. This is a group in New South Wales. It's a networked wide implementation of guidance across 12 hospitals, including paediatric hospitals, where they found that, you know, progressively implementing it and embedding it within the order process continued to enhance its uptake and also appropriateness. And this is a very nice paper by Pam and the team around the impact of the digital program, demonstrating the improvement in patient outcomes. And many of the guidance advice papers that we've done at Royal Melbourne really a substantial proportion of the literature around the impact of digital programs. So this is the model that we have where guidance sits and is embedded with the electronic medical record, the approvals and decision support and post-prescription review. We upload antimicrobials. We try and support the prescribing process. It is not easy because, as you well know with your EMR, how difficult it is to add in a third-party program. It's exactly the same with every EMR. But we have built out some interoperability pieces that are very important. And at the moment, it's in about 53 hospitals, public, private, statewide implementation in Tasmania, major cities and regional cities with various, I think you have Track Care as your EMR, don't you?
Yeah.
Yeah.
One of the most painful.
Yes, yes, it is very painful. So we, like you, are still struggling to understand how we can optimize integration. And this is Zohar, one of my amazing pharmacists, who's been working with with the technology team to use an interoperability language for CDS, for clinical decision support called CDS hooks, where we're going to try and embed it seamlessly into the prescribing program. This is a universal indications list. I'm just showing it to you because one of the things that I think is really, really, really important, that we need to each have the same language when we're talking about infections. And we spent years developing this program with SNOMED coding every antimicrobial indication. And there were dozens that weren't coded. For example, surgical prophylaxis had very few meaningful codes. So we worked with the Digital Health Agency in Australia to build up these codes. So now we have a very comprehensive set of codes. It forms the backbone of the NAPS platform, which has been used in 15 countries, so that we know that the current indication list is pretty good. But every now and then we get requests from different countries, like Nepal, to say, well, we want this, this, this. We have a central committee, a multidisciplinary committee. We discuss any new codes, whether there needs any coding change. We include, for those countries that want to use it, tag words so that, you know, many EMRs have character limits for indications so that they can adapt it for their own use. And that this is seems boring, but a very important piece. Yes,
So
yes.
You mean that you have open data set, standardized
Standardized
data
set for all infections.
Wow.
So this is available for licensing particularly for research. This is a really important asset.
This is one of the most important.
Yep.
Okay.
It's a very important asset, and we know because we've used it for years now that even in Fiji or, or Canada, it's fit for purpose. Now, this is just some screenshots of guidance, just so that you know. You can see here are the UAL, here are the indications, and here is the WYSIWYG tool. So you can build out a guideline and it converts into code, and then you publish it into guidance. This allows all sites that take on guidance to adapt the decision support to your own use. And we have already built out decision support for pediatrics, obstetrics, and adults. We have experts that provide that information. But you can see here that people wanted to look at decision support either by drug or by indication. And you can see, I think the question to you is, well, can this be done by AI? I said not in the near future, because we've decided people need to have decision support delivered very quickly. You only have junior residents about 7 seconds to get their answer, but we have developed out the decision support based on key important questions, and they have direct access to the national guidelines, and it will also tell them if they don't meet the guideline. However, they can still prescribe as long as they put in a reason. So we know that approval restriction programs, you can't stop them prescribing, but you need to capture why they're prescribing. And we've known that for a long time. What happens is when you jump into the electronic order entry, it will come up as soon as you try and prescribe something, and it automatically logs in, allows them to do the approval and go back into the order. We also allow all antimicrobials to be uploaded into the platform. Yes.
First, in
Yes.
previous
Yes.
topic, you said that the approval that obviously is based on national indication
And
for-
local.
Okay, and
Yeah,
local drugs.
very important.
Is automatically approved without reviewing of patient's data. How long?
Typically short approvals, 48, 72, sometimes single. And there's highly restricted, yes. So that comes up into your patient list, and then I'll show you in a minute. Actually, let me see. That show it to you. Or maybe it's coming in a minute.
Yeah.
Okay.
Sorry.
Now you can see here, it develops a patient list. So you can see all their antimicrobials. So if you've got a patient that's on cefalexin as well as metronidazole and meropenem, you're able to review all their antimicrobials because we import all antimicrobials before the round. That means that instead of being just targeted on a particular drug, you can look at the patient altogether, and you can look at all patients or filter by patients that need review. And we've also built in that concept of that alert indication. So you in your own organisation can choose which antimicrobials an alert. So for example, you might want to flag every linezolid. I mean, I don't know how they come to your attention, but in our hospitals, if 40% of every patient is on an antimicrobial, it's impossible to see everybody. So therefore you need to have some way of triaging. Then once your round is complete and you've finished it off at the end of the day, you can then go back and do a targeted assessment. You could do every patient, or you can just do a targeted assessment. And this is where we utilise the NAPS, many of the NAPS criteria that I talked about before. You can send your recommendations, flag for follow-up by the unit, flag referrals. It's a very flexible program, so it depends on how it's used. And then lastly, this is the reporting. This is something which we didn't do well in the past, but most hospitals don't want to spend hours creating reports.
No, she's smiling. She said she doesn't want to talk after this. Because we are getting so depressed and then, Okay.
But, coming to this looks really pretty. And the reason it looks really pretty is because one person joined my team 5 years ago, and she's the most valuable person in my team. She's a graphic designer and a UI/UX designer, so user experience designer. And she did formal usability testing with managers, with junior doctors, and she did the formal assessment of whether or not they will trust it and believe it and use it. Now, she's my luxury in my department. I'll never let her go, but I love having her. She's amazing. She's incredible. Now, I'm not going to talk about this much other than the fact that it's a huge movement in Australia. Hopefully you'll have Jason Tribbiano coming. Did he email you?
Yeah.
Oh, good. So you'll have Jason, the world expert on antibiotic
Probably
delivery.
he will be here in October.
Excellent.
For a week.
Well, you can hear him speak, but it's incredible now. It's like a religion or a cult for Jason. And I would suggest probably pretty difficult for you to execute in this hospital. Now, there's my last two slides. This is what has driven my research for many years. So in my first Centre for Research Excellence, how would you prescribe it? Can we measure it? Is there a national surveillance program? What drives inappropriate use? This is that behaviour change. What's the best framework for AMS? What do we do to improve prescribing quality, and what actually works? And so this is a new grant that I have. Again, another $3 million grant, and again, it's a digital one. And these are the sorts of things that I'm interested in now. We don't know the best way to do audit and feedback. The evidence is very unclear as to what is going to change someone's opinion. How do we give feedback to our managers compared to our junior doctors? We can never get to the real decision makers or surgeons because they're not interested in this sort of data. So how do we do audit and feedback? What are the frameworks? How do we develop stewardship programs in some of these other areas, particularly in the community? So this is my last slide. I've probably gone a bit over, Evelina, but I think if you're going to ask me what the big drivers were for stewardship in Australia, 100% it's the accreditation. You saw the detail. But I also acknowledge that in order to do stewardship effectively, you need to really think about what structures and processes are feasible in your organisation. And that's why there's no cookie cutter here. There's no cookie cutter. You need the time and space to understand what you can do. So that's it. I was going. Oh, okay.
Do we have any questions from the participant online or here in the room?
It is called.
You have to repeat the question.
The question is guidance a medical device? The answer is it's a class 2 exempt medical device. What that means is it is registered as an exempt medical device, but in order to prove it's exempt medical device, you need to have a quality management system. That quality management system, which is ISO standard 13485, usability, cybersecurity, that took us 2 EFT and 3 years to put in place. So this is not for faint-hearted, but in order for us to distribute it and license it out to hospitals, we have to do that. And also you have to have a post-marketing surveillance in place. So any critical event so we have a triage process. So just before I came away, there was one that needed a root cause analysis because it was creating the approval number wasn't displayed properly in one of the hospitals. So this is something which I have learnt. So in my own department, I have my business manager, Steve. He's a PhD in biotech. He has learned how to do this. Again, it's not a skill. Most people want to build apps, they want to do this, they want to do that, they want to use AI. You really need to be very, very careful before you step into thinking that you can do it for your own hospital, that's fine, but the minute you want to use it anywhere else, then that triggers.
Maybe I have a question. If I understand, you have national guidelines.
Yes, we do.
Which would make a huge difference.
Massive difference.
So can you describe who is doing the national guidelines?
Yes.
How often they are
Yes.
updated and
Yes.
how everything is organized?
Yes, so yes, I do. So Evelina wants to know how we got to that point with the national guidelines. So they have actually been there since 1978. They're up to the 16th version now, and they have typically been, it was a little pocket book that everyone carried around before internet came along, a little book about that thin. Then it became about, I'm showing about an inch thick. Then they developed it into an online resource, and it was called the ETG, Electronic Therapeutic Guidelines. This time around, they've dropped the electronic because everything's electronic, and they're back to therapeutic guidelines. It was, I would say that it was a bit of a boys' club to start with. There were sort of a few people saying this is what we should be prescribing. There was a bit of backlash from some of us that felt that they needed to be more consultative. And so the last few versions, for several versions now, they have writing groups. So there'll be a writing group in charge of sepsis, respiratory tract infections, immunocompromised hosts. Those writing groups are given the previous version. They're required to do a evidence-based update, but they're not done against agreed criteria. So they will tell you that they're not evidence-based. It's more committee-based decisions. So I haven't always agreed with them. For example, the last sepsis guidelines I thought were terrible. I would never use them. But anyway, they've continued to mature over the time. They are funded at the moment for all public hospitals. So anyone else would need to get licenses. They do have a foundation. So they also help countries like Bhutan, Fiji to develop a version for themselves. And they typically would do they used to do upgrades every 2 or 3 years. They're now moving to a live guideline. So this version now becomes a live document. Now that makes it difficult for those of us developing decision support, of course, because we need to keep track of their changes. So my group in guidance and in NAPS, they use our data from NAPS. So I can send the writing group. A good example was showing for hospital-acquired pneumonia, there was quite a high proportion of prescribing of azithromycin, which is not recommended. So we sent back the appropriateness prescribing around hospital-acquired pneumonia back to the writing group.
Versus
versus ceftriaxone. They were adding in azithromycin for hospital-acquired pneumonia. Hospital-acquired pneumonia. Hospital-acquired. We sent that data to the writing group so that they'd made a specific statement that macrolides are not required. So that is a nice way of using our appropriateness back to the writing group. And we actually have a contractual agreement with the therapeutic guidelines to be able to use their actual pages within the decision support tool.
Who are the core group? So
they have an executive.
It's not a scientific society. So who are these three?
They have an executive committee, and the CEO is a pharmacist by background. They have it's basically it's like a publishing company really, and then they contract in pharmacists and clinicians to create these working parties. They're not paid, they don't get paid, and they do a lot of work to pull together the guidelines. So I would see it as and it's not just antibiotics. So they have guidelines for cardiac,
it's an external company.
Yes, not for profit. They have it's not for profit. They have a foundation which supports research, and they really you know, it's a lot of work. So these poor clinicians, can you imagine doing these?
Yeah,
Takes
we
months to
do it. Yeah.
No, it's huge. It's huge.
Yeah.
Now, the one thing I've managed to do though is because Monica Sabin and I oversee the national consensus guidelines for fungal, which are done according to the grade criteria. We do the fungal guidelines, which I've sent around to some of you, and also the neutropenic fever guidelines, which we're updating now, which again are done against the grade criteria. I have told therapeutic guidelines, you must wait until they're published and then use that recommendation, because I don't want your writing group to go and do a parallel set. So they're pretty good about that now. So they say, oh, Kaz, when are they ready? They're coming. When are they coming? You just need to wait. Yeah, but it's a big undertaking, and I think it is very unique internationally, the sort of detail in these guidelines. And it's not just around, for example, Jason now has got all his allergy stuff in there now. There's a lot of technical information about PKBD, which I think is something that I see many of our doctors have a big knowledge gap on, PKBD, I think. So they've become too big to be a book. You can't put it in your pocket anymore.